Good morning, everyone, to the Buncke Clinic Virtual Visiting Professor Series. This morning, we have the distinct pleasure of welcoming a very dear friend of mine and a very dear friend of the clinics, Dr. Kyle Eberlin, from the Massachusetts General Hospital, Harvard Medical School. I've known Kyle for many years, and he's become one of my closest friends, actually. I'm going to do a couple of slides of intro just by way of background for Dr. Eberlin. Dr. Eberlin obtained his BA and MD from the Boston University, where he was summa cum laude in both, and he was first in his class in his medical school. He then did his residency at the Harvard Combined Integrated Plastic Surgery Program, and he stayed in Boston to do his fellowship at MGH under Jesse Jupiter and his colleagues. He was then hired on, and he stayed at MGH, and his career has really seen a meteoric rise over the last few years. He is currently the program director of the Harvard Plastic Surgery Residency Program, which, as we know, is one of the premier programs in the country and one of the largest programs as well. So a very big job that he has undertaken in addition to his very busy clinical practice and his research practice. He's also the associate director of the Hand Fellowship at MGH. So clearly even more work that he's doing in that regard. He was the 2018 and 2019 plastic surgery visiting professor for the American Society for Surgery of the Hand. And this is an award that's only given to 2 people per year, so a very prestigious honor. In addition, Dr. Eberlin was chosen as the 2020 Traveling Fellow for the American Society for Peripheral Nerve. Also a very high honor. Unfortunately, this year with the travels, I'm sure he's having to postpone some of these until next year. He is on the board of directors of the American Society for American Association for Hand Surgery. This is a typo, pardon me. He's also on the board of directors of the American Society of Plastic Surgeons. And also, in addition to being very clinically busy and also a very prolific researcher and publisher, he's also a consummate educator. And in 2017, Dr. Eberlin was awarded the Julian Privas Teaching Award at the Harvard Plastic Surgery Training Program. As we know, Harvard is a very large program with many faculty. So getting this award among the dozens and dozens of faculty that they have, honestly, is quite a feat, and is obviously a very difficult thing to get. At a very young age, Dr. Eberlin has already published over 100 papers. So he clearly, like I said, has seen a meteoric rise, and I think we're going to continue seeing him make very big moves over the next few years. On a personal level, I've gotten to know Kyle very well. We've probably taught dozens of cadaver courses. Here he is speaking during one of our cadaver courses. We've taught these all over the world, and certainly all over the US, and we usually host a program either here in San Francisco, and then he hosts one in Boston, and we usually travel back and forth. I personally have had the pleasure of visiting Kyle actually on 3 occasions. They've been kind enough to actually invite me to give a lecture. This was this past year during my travels. So very close bond with all of our friends in the Harvard system, but in particular Dr. Eberlin, and I think it's been a very close friendship and one that I value greatly. I had the pleasure of visiting Dr. Eberlin at MGH last year during my travels as well, and to see him in his element. It was a great day. Fantastic case in the OR with a complicated microsurgical cranial coverage, and also a very busy clinic with really complex patients, mostly upper extremity, peripheral nerve, and plexus. So that was a lot of fun. And Kyle, thanks so much for hosting me during my day at MGH. With that, Kyle, thanks so much for being with us again. This is really an honor to have you here, and we appreciate you taking the time out of your very busy schedule, as we all know, to give us this talk. So I'm going to make you presenter here, and give me 1 second to find you in the list. There you are.
Great.
Okay. Perfect.
All right. So is my screen being shared now?
Yep.
All right. Well, thank you very much, Babak, for that really kind introduction, and it's a real honor to be here. I will say that overall, I've learned an unbelievable amount from you and from Dr. Buncke, who is here as well, and really from the whole Buncke faculty and the Buncke clinic. So it's a real honor to be here, and a lot of what you guys have done have shaped my practice and the way I approach patients, and I'm really grateful for that. I'm also grateful for our friendship, and it'd be great when we're able to get together again in person and either teach courses or even just see each other. So with that said, we'll move on to the talk. I'll be talking today about the management of surgical management of symptomatic neuromas. And I think this is a really interesting topic. I know that you've had a lot of other great speakers in this give talks about the management of different types of nerve problems. And what I'd like to do today is kind of frame the discussion about where we are in 2020 for the management of symptomatic neuroma. It's a topic that I'm very interested in, both in a clinical standpoint and also a research standpoint. So we'll get underway. I apologize in advance if I'm a bit foggy. I did a hand replant last night, as we were just talking about, so haven't really slept in a while, but I'll try to be as clear as possible. I think overall that the management of neuropathic pain and management of neuromas has historically been an unsolved problem in surgery. If you look at the top of the screen, you have a distal radius fracture. We have many different ways to treat that. You have a lot of different plate and screw constructs. They all work pretty well. But when you have a patient with significant neuropathic pain, whether it's an amputation, whether it's a different type of trauma or surgery, it really can be a major problem. And I think it's historically been an unsolved problem. For those of you that know me, many of you know that I'm quite obsessed, perhaps in a hopefully healthy way, with chess. And I think there are many parallels here, along with peripheral nerve surgery and surgery for neuromas. I've always thought that we could do a better job than we have done historically. And if you look at some of the historical literature, you'll see 50% success rates, almost flipping a coin. And I think we've come a long way in the year 2020 and have made some really great advances that I will hope to share with you today. The reason that I'm interested in this topic and have become interested in it is that I take care of a lot of patients with extremity injuries. And in really getting to know them well and taking care of them over time, pain is a major factor related to their outcome. I've also found that if you do something with the nerves early on, and early nerve surgery, even concomitant nerve surgery, you can obviate many of these issues. So it's become something I've thought about more and more. And also, and I'll share some of this at the end if we have time, but patients with chronic pain, particularly amputees, really can benefit from surgical intervention for their neuropathic pain. So this is to frame the discussion why I got interested in this. So here's an outline for what I'll talk about for the next 45 or 50 minutes or so. We'll go through a brief introduction. I want to spend some time delving into neuromas, their pathophysiology, the way we diagnose them, and some of the treatment options. I'll briefly go through the contemporary neuroma treatments, including TMR and RPNI. I'm not going to dwell on the specifics there because I know Paul Sedurna and Greg Dumanian have given talks about that, but I will share some of the newer things that we're doing in that realm. And then lastly, if we have time, I'll go through kind of my algorithm in our clinic for how we evaluate amputees for neuropathic pain, which I know is a growing area of interest around the country and around the world. I will also say that, you know, if anyone has questions, feel free to stop. Hopefully we may have some time at the end for some discussion, but we'll get started. Okay, so neuropathic pain and neuroma pain is way more common than most surgeons think. And I like this quote a lot from Robertson Davies: "The eye only sees what the mind is prepared to comprehend." And what this means is that if you as a surgeon are not paying attention to this and thinking about it, not only will you miss it, but you'll miss opportunities to treat these problems and make the patients better. So you have to be thinking about it in order to diagnose it and to take care of it. If you have a trauma or have an operation, there are many different reasons that someone can have pain afterwards. There is nociceptive pain and there is neuropathic pain. We're going to focus primarily on neuropathic pain here, which is pain related to the nerves themselves, or nerves specifically, although there are many other reasons that people can have pain after trauma or after surgery. You might say to yourself, well, everyone that has surgery or has trauma has some degree of pain, and that's absolutely correct. But when does it become a problem? The International Association for the Study of Pain would say that if you have pain for at least 2 months after a major trauma or surgery without any other identifiable or explainable cause, that this inherently is pathologic. I'm not certain that I agree with the 2-month time frame. I think the window is actually a bit longer, and there are patients who have pain for 3 or 4 months and then it gets better. But it's definitely true, in my opinion, that if you have a patient with pain that lasts more than 6 months or even 9 months after a trauma or surgery, that there's something potentially addressable, and this is what we as surgeons should be thinking about. When you look at some of the granular data about the rates of neuropathic pain or even chronic pain after different types of surgeries, it's really remarkable, and the numbers are quite striking. This is a study from The Lancet in 2006. I'll highlight the fact that amputees themselves have a 30 to 50% incidence of chronic pain and a 5 to 10% incidence of severe disabling pain. So that's well and good. People generally know, and surgeons generally know, that amputees can have pain issues over time. But if you look at the other procedures on the slide, thoracotomy, CABG, inguinal hernia repair, very significant rates of chronic pain. And I would argue that most of these are neuropathic and due to potentially identifiable and remediable injuries. Here's another study showing basically the same thing. 30 to 85% incidence of chronic pain for amputees, and all sorts of other procedures have significant rates of chronic pain. I would argue that any incision made in the body can be a significant cause of neuropathic pain, and particularly in my practice, the lower extremity is a primary culprit in this arena. Here's just a random picture of the different incisions that can be made. You can see the sural nerve highlighted here. You can see the superficial perineal nerve highlighted here. And the bottom line is that any incision in the body can traverse a major nerve, a minor nerve, or even a branch of one of those two nerves, and that alone can cause discomfort and can be a source of frustration for the patient. So we're going to move on for a moment to talk specifically about neuromas. We'll get into some more detail about that. I'll share some of the research that we've done here and my overall thoughts about where we are in 2020. This is a rapidly evolving field, and I would say that if you rewind 5 or maybe even 10 years, this type of discussion would be fundamentally very different than it is today. So neuromas, by definition, are a disorganized growth or tumor of nerve tissue following a nerve injury or a transection during amputation. So everyone sort of knows that. But it really occurs when a nerve is not connected to its target, whether that's a sensory or a motor target. And if you think about amputees, every single amputee, no matter where the amputation is, if you don't have something like TMR or RPNI done, every single amputee will have a neuroma. Not all of them are symptomatic, but everyone will have a neuroma. So I think the nomenclature and the way we think about it needs to be clarified a bit. So generally speaking, when we're talking about neuromas, what we're really talking about are symptomatic neuromas. And that distinction, I think, is important. So back to basic science just for a moment here. You have a nerve with an origin and a target. You have a nerve injury seen in red. You get Wallerian degeneration distal to the nerve injury. Your axons sprout, and if those axons are not connected to any target, you get a neuroma. And this is how it happens. And we've all seen this numerous times. Here's a picture of this. What we can see in this slide is that you have a bulbous, firm ending to the nerve. And it's interesting to see the caliber change of the nerve at the site of the neuroma. And one of the things that I've been curious about, although I don't think anyone has proven this one way or the other, is whether the size of the neuroma itself relative to the caliber of the nerve is in any way predictive of pain. I've tended to find that the larger the neuroma, it seems that those are the places where the pain is most profound, but I'm not sure we know that definitively. So one research question that came up is, how do we even diagnose a symptomatic neuroma? We started writing some papers about this, and a lot of the reviewers would come back and say, great, you took care of patients with nerve pain, but how did you know they had neuromas? And the gold standard of a neuroma diagnosis is, in fact, to excise the neuroma, send it to pathology, and have them look at it. But you don't have that benefit before surgery, clearly. So you have to make the decision about whether you think they have a neuroma prior to intervening, and that's where this sort of comes into play. So because there were no accepted criteria, we performed a meta-analysis to determine some criteria for diagnosis. And we looked at 4 different things. So patient symptoms, their physical examination findings, whether or not they had a diagnostic nerve block, and finally imaging to determine if they had neuroma. And meta-analyses are not perfect. This was published in Annals of Plastic Surgery last year. I'm happy to share this with anyone that would want. I'll have my email address at the end of this talk. You can email me. I'll send you any of the papers we've written. And we looked at the numbers of studies that have investigated this, the Tinel sign, pain, ultrasound, etc. And here is what we have come up with. Here's the bottom line for this paper, which I think is practically useful for people, hopefully. In order to be diagnosed with a symptomatic neuroma, I believe that you have to have all 3 of the items in the red rectangle at the top of the screen. You need to have neuropathic pain. You need to have symptoms in a defined neural anatomic distribution. and a history of nerve injury or suspected nerve injury. So that could be surgery, could be trauma, could be anything like that. And I believe that you have to have at least one of the criteria in the bottom blue rectangle, which is a positive Tinel sign, response to a local anesthetic injection, or some sort of radiographic confirmation of neuroma. I think that these criteria are much more sensitive than they are specific, but I think it gets us on the same page in talking about these patients as opposed to saying, oh, we're pretty sure they had neuromas. So now that we've talked about how one diagnoses symptomatic neuroma, let's talk about where they occur in the body and where surgery is done for them. This is a study that we published in this past year in June in PRS, where we looked at, in our system, a large series of neuromas, over 600 neuromas, 641. And we looked at the descriptive statistics about where these neuromas happen, how many of them have secondary surgery, et cetera. And here's sort of what we found. This is a busy slide, but I'll just highlight a few points. If we look at the cause of these neuromas that were treated surgically, the ultimate etiology in about half of the patients was trauma and almost half the patients was surgery. So it's almost evenly distributed between a traumatic etiology as well as a surgical etiology. And when we look at where these surgically treated neuromas occur, about half of them were in the lower extremity and half of them were in the upper extremity. And there were some scattered ones in the groin and abdomen. And I would say that, frankly, the reason that these numbers are distributed like this is because historically, these are the only neuromas that we were really treating. But I think chest wall neuromas after mastectomy, from intercostal neuromas, these types of things are becoming much more apparent to us as peripheral nerve surgeons and something we should be aware of. When we get a bit more granular about this data, in the upper extremity, digital neuromas are the most common, not surprisingly. You can see the other distribution here. And in the lower extremity, Morton's neuromas, which are honestly a separate category here, were the most common, followed by sural and superficial perineal nerve neuromas. And I find the sural nerve neuromas a pretty interesting category because, as we all know, this is our very common source of autologous nerve graft. And a lot of these sural neuroma patients had prior foot and ankle surgery or some sort of traumatic injury, but a few of them did in fact have sural nerve harvest for autologous nerve graft. So it's just something important for us to keep in our mind. So the important question, which I guess everyone's probably thinking of, and this is the reason that we are surgeons, is great, you know how to diagnose them, you know where they happen, but how should we be treating them in 2020? So I'd like to focus for quite a bit of time on this exact topic, which I think is really the new aspect of our surgical care for neuromas in the past couple of years. This paper that I wrote with Ivan Ducic, I think is a reasonably good summary of where we are in today's day and age, which was in PRS Global Open in 2018. And this is perhaps the most important slide in my talk, which is to say that we have really undergone, I believe, a very profound paradigm shift between a passive approach to neuroma treatment to a more active approach to neuroma treatment. And what I mean by that is that if we look historically in how neuromas were treated, the nerve ends were resected and either left alone or buried in muscle or buried in bone. And we'll go through some of the data. And although that can work, and that was described in a very seminal paper by Lee Dellon and Susan McKinnon in the 1980s, I believe that we have shifted to a more active approach to the nerve endings. And what that means is we're giving the nerves a job to do. We're doing something with the nerve ending that confers a functional destination to them. And very often in my practice, that involves reconstructing the nerve with either allograft or autograft, doing targeted muscle reinnervation, or doing regenerative peripheral nerve interface. Again, I'm not going to dwell on the background of all of those, but I want to really frame it at a high level. But this principle of going from a passive to an active approach, I think is very important in the year 2020. So when we're thinking about neuromas, we first need to think about whether we have a neuroma in continuity or whether we have an end neuroma, because the treatment of those two things are in fact a bit different. If you have a neuroma in continuity or a neuroma in which the terminal end of the nerve is available to you, most often a common treatment would be to reconstruct the nerve, to reconstitute its function. If you have an end neuroma, there are many more options available to you, and we're going to go through some of these in some detail, but you can excise and implant it. You can use a nerve cap, which are now commercially available by a few companies. You can consider a central neurorrhaphy, relocation nerve grafting, and decide TMR and RPNI. And again, we'll go through some of those in a few moments. But if we have the distal end of the nerve available to us, reconstruction is often a good thing to do. And this is just another schematic that highlights those overall principles. Another article that we've written in the past year or so with my good friend Ivan Ducic is where we looked at using nerve allografts for reconstruction of neuroma-induced pain. And the case I'm about to show in a second kind of highlights that. I'm sorry I didn't put a disclosure slide in the beginning, but I am a consultant for Axogen. I think that's worth saying here. But let's go through this patient to provide a little bit more clarity here. So this is a very, very nice middle-aged woman who previously had a fibular fracture that was treated. She had a neuroma of her superficial perineal nerve that an orthopedic surgeon excised and buried into her fibula. And she still had a tremendous amount of pain. And she went through her life, you know, she sort of lived her life. She was out and about. She actually is married to a CEO of a hospital in the Boston area. So they're a pretty well-to-do family, but she sort of lived her life and just had a lot of pain. And you can see by looking at her leg, the star indicates exactly where her pain was. So the diagnosis here is not rocket science. You know, this is a neuroma of the superficial perineal nerve that still is painful. And my assessment here was that, you know, I look at the length of the incision. I believe that I'm able to find the proximal and the distal ends of the superficial perineal nerve. So my plan, generally speaking, in these cases, is to rebuild the nerve, is to reconstruct the nerve, commonly with nerve allograft. So here we go. When you explore the leg, it looks like there's a bit of a lag in my the slides that I'm bringing up. So I'll try to talk a bit more slowly so we can highlight each individual slide. But Babak, are you able to see my mouse pointer here or no?
Yes, we can see it.
Okay, thank you. So what we can see here in this slide is that you have the superficial perineal nerve, and this is exactly where it was buried into the fibula. You can see it's quite inflamed, and that's exactly where the site of her pain is. We can also appreciate the distal end of the nerve, the medial and the lateral branches of the superficial perineal nerve. And so my plan here, very simply, was to resect the neuroma. We have a nerve gap that's approximately 7 centimeters, and to reconstruct the nerve. And here you see a nerve allograft which go up to 7 centimeters in length. And this is really about an hour type case. And I'll play a video in a second which shows kind of where she is at about 9 months out from surgery. And hopefully the volume will play. If not, I'll just narrate it. Okay, so we're about 9 months out from surgery after resection of the superficial perineal nerve neuroma and allograft reconstruction in about a 7 centimeter gap. And so the neuroma itself is kind of right here, but you can see the incision's well healed. And do you have any pain along the course of the nerve here?
No, I do not.
Okay. And tell me a little bit about the feeling on the top part of your foot.
Well, when I first saw you, I had no feeling on the top of my right foot, and 3 or 4 toes.
Mm-hmm. How does it feel now if I were to examine you kind of here?
I now have feeling on the top of my foot,
okay,
which I did not have. And I feel 4 out of the 5 toes. 4
out of the 5 toes. And just to quantify the amount of feeling from 0 to 10, 10 being normal feeling and 0 being no feeling, what would you quantify that feeling on the
I would say that I'm probably at a 7 at this point.
7 out of 10. Great. So we're 9 months out and the pain is gone at the site where it was initially. Is that correct?
At the site where it was initially.
Okay. Excellent. So if we pause for a second and just think about the context here, this is a patient who had a relatively conventional neuroma technique previously with a significant amount of pain that in a relatively simple operation, which doesn't require a ton of expertise, frankly, we're able to reconstruct the nerve and confer a significant benefit to this patient. Not only is her pain better, but she has recovered some sensibility in the dorsal part of her foot. So this is a win-win overall. And again, high level here, if the nerve is if there's a neuroma continuity or the terminal end of the nerve is available to you, reconstruction is often the best thing to do, in my opinion. When we look a little bit more closely at this, this is a paper actually just came out a few months ago. We looked at a large series, relatively large series of digital neuromas that were treated surgically and have really long-term follow-up, almost 8-year follow-up. And this was published in PRS in the past few months. And we wanted to look at the factors that were involved with which patients did better after the treatment of digital neuromas. And you can see that here are the treatments that were performed: excision with nerve repair or reconstruction, excision of the neuroma alone, or excision and implantation, either in bone or in muscle more proximally. The bottom line in this paper is that nerve reconstruction, so reconstituting the nerve function, most commonly with nerve allograft, appears to be superior to just excising the nerve or just excising it and burying it in muscle or bone. So giving the nerve a job to do, restoring its function, appears to be better over a long term, again, over 7-year follow-up on average for these patients. And I think that that's important, and that mimics my experience clinically with a lot of these patients, and it's something to be aware of. So if we go back into the treatment of neuromas and kind of the schematic here, if we have an end neuroma, and I mentioned earlier what the techniques are, I'm going to highlight a bit on this slide that what I think the overall things you can do with an end neuroma. So you can excise the neuroma and implant the nerve into muscle, a la Dr. Dellon and Dr. McKinnon. Nerve caps I mentioned. Something called a central neurography, which can be useful particularly for digital nerves. I'll show some other techniques, but digital neuromas you can use that for. A technique called relocation nerve grafting, where you put a very, very long, or the longest allograft that you're able to at the end of the nerve, and provide a long runway for that nerve to regrow through to make its way into a different area, and use the benefit of having a very long regeneration distance to your advantage. And also the techniques of TMR and RPNI at the bottom of the screen, which I think are great advances in the field of peripheral nerve surgery and in neuroma surgery, frankly. So let's talk for a second about nerve implantation, where this fits in currently. So as mentioned, this was first described by Dellon and McKinnon in the 1980s. You can bury it in any number of structures. There have been some reports with reasonable success. And here's a case of mine very early in practice, which I would treat differently now. This is a sural neuroma, which you can see the medial and lateral nerves, sural nerves coming together. The patient similarly had a neuroma excision and bearing previously. You can see where the star is near the ankle, where the site of pain was, and again, corresponding exactly to where the neuroma is. So in this case, again, a number of years ago, I excised the neuroma, which you can see here. I buried it deeply within the medial and lateral gastrocnemius heads, and left enough laxity in the nerve so that it wouldn't come out with ankle flexion and extension. And this patient actually went on to do okay. I think that in 2020 we have lots of techniques at our disposal. There are some indications, I believe, still for nerve implantation, but more and more I think we're moving to that more active approach for the treatment of neuromas. Another technique that is useful and you should consider, I believe, is a relocation nerve grafting technique, and I'll show a case of this as well. So this is kind of nerve graft to nowhere. And it's something that we published about 1.5 years ago in Journal of Hand and Microsurgery, just a sort of case report. But this is a guy who had a lawnmower injury to his hand. You can see as a distal thumb amputation, index finger kind of pseudo ray amputation, and a middle finger amputation at the level of the PIP joint. Treated elsewhere, sent to me because he had very significant and profound neuropathic pain in the first web space. You can see where these dots are here, kind of right at the base of where the index finger was. That's where the main site of his pain was located. So when you explore him, not surprisingly, you find large bulbous neuromas of the digital nerves to the index finger, and corresponding exactly to where his pain was. And the question is, of course, what do you do about these? You're relatively limited in your options. There's no finger there for you to graft towards. There's not a super long length of the nerve itself because, of course, unless you were to do an extensive intraneural neurolysis of the median nerve, it's hard to get it really far out of the way. And once you excise the neuroma, you have a pretty short nerve stump. So in this case, what we did was, I'm sorry for the little shifting view here, but excise the neuromas. I did a revision ray amputation. You can see that the second metacarpal is obliquely cut a bit more proximally, which I think is a bit better way to do the ray amputation. And I put in these nerve allografts and I tunneled them dorsally. So allowing the nerve generation in the axons to traverse away from the working surface of the hand in the first web space toward the dorsal side of the hand. So again, think of this as a highway for the nerve to regenerate, and it's eventually going to either peter out or not be as strong at the end as it was at the beginning, and that's the whole point. So relocation nerve grafting, I believe this is an indication to consider it in one's practice. And you can see here that the nerve grafts are tunneled into the interosseous muscles. All right, so again, highlighting the fact that we've gone from a passive to a more active approach for the treatment of neuromas. So I'll move on briefly to some contemporary treatments for neuropathic pain and to highlight some of the, I think, recent advances in the techniques of TMR and RPNI. So an easy way to talk about this is to talk about amputees, because in amputees, by definition, the distal end of the nerve is unavailable, and by definition, amputees have neuromas. So you sort of know what you're dealing with to be when you start. And I think TMR and RPNI have become the cornerstone in 2020 of management of amputees, and I think have made a tremendous advance for the field overall. And I think what's also interesting is that we, as plastic surgeons and reconstructive microsurgeons and peripheral nerve surgeons, are leading the charge in this field. And I think that a lot of our colleagues in orthopedic surgery and vascular surgery and in general surgery, I think are coming along. I think we have a ways to go to show them where we are in 2020, but we're on our way. So targeted muscle innervation, is, I'm sure everyone pretty much knows, is a technique that was initially developed to improve the function of myoelectric prosthetics, and serendipitously has been discovered to profoundly improve post-amputation nerve pain. And the concept is to do a nerve transfer between the donor nerves, which have no residual function, into surrounding and adjacent motor nerves to provide a functional destination for the nerve. So if we think about how amputations are performed, they've historically been performed the same way since the Civil War. And if you think about your practice, think of what else you do in surgery that's been done the same way since the Civil War. Almost nothing, right? There's almost been a point of pride of other surgeons about how fast they can amputate a limb, whether it takes them 7 minutes or 12 minutes. And frankly, I don't think that's the best way to do an amputation. And I think we put a lot more care and attention into it. And I think that's where we all should go. And if there's anything else I can implore you, that are anyone listening to this, is to, in your own institution, to beat the drum about this. I'll share some thoughts at the end about how we've kind of built our amputee center, which really has stemmed a bunch from our Neuroma practice. But I think that this is an important advance in plastic surgery. The credit for TMR specifically should go to, and does go to, Greg Dumanian and Todd Kuiken, who developed this technique and really have popularized it, written all the seminal articles, and we're very indebted to them for their work in this arena. And similarly in RPNI to Paul Soderna and the Michigan group for their seminal work on RPNI. But here's how TMR works. I'll go through this briefly in case anyone's not aware. I assume everyone probably is, but you have an individual with an amputation, in this case a 4/4 amputation, and you have the nerves of the brachial plexus, which are no longer connected to the limb. The idea of TMR is to locate adjacent motor nerves, which are innervating various muscles nearby, in this case, the different segments of the pectoralis major, to reroute the nerves of the brachial plexus, and to do end-to-end nerve transfers between the donor nerves of the plexus and the recipient motor nerves along the chest wall. Once you get familiar with this technique, it's not particularly difficult to execute, I would argue. You do need to know the anatomy extremely well, and you do need to know kind of what the variations are and what length you have and what might be synergistic. But as long as you are able to do something to these donor nerves, it really is a very, very successful technique. And you can hook up EMGs and electrodes and power up prosthetic. So initially, it was designed for myoelectric prosthetic function, but serendipitously was found to improve post-amputation neuropathic pain. Just to really quickly highlight some of the articles about this, just for everyone's edification. The reason we think this works is because it gives a nerve ending somewhere to go and something to do, which is a term coined by Greg Dumanian. And this is probably why pain is improved. And this also lends itself to the other neuroma techniques, which is to say that we're doing something active with the nerve endings now. And if we do something active to the nerve ends, the brain is satisfied. It closes the circuit. And the way that I often explain this to patients in the office is that if you have a live wire sitting around your house that's not connected to anything, That's obviously not a good thing. And what's the treatment? You want to rewire your house. You need to get that live wire attached to something. We don't have no way to deaden it completely. That's not the way the body works. But rerouting it will confer that function to it and will improve its painful component. This was first described almost 10 years ago now by Greg Dumanian's group, our good friends Jason Souza and Jason Coe as well from Northwestern. And this was, again, serendipitously discovered, and I think has become extraordinarily commonplace in a lot of major centers around the country and around the world, and will likely increase in frequency over time. Briefly, this was a study in the Annals of Surgery for delayed TMR. So these were patients who had established amputations with established neuroma pain, were randomized to either standard technique of excise, cut the neuroma out, bury it in muscle versus TMR, and the results were very significantly beneficial for TMR. This paper in the Journal of American College of Surgeons was looking at acute TMR, which is doing TMR within 14 days of an amputation. There are a variety of etiologies for the amputation, different levels, but the point is that similar to the delayed TMR, when you do it acutely, the results are very, very impactful. And you don't need to be an epidemiologist or a biostatistician to see the p-values being extremely significant on the right side of the screen for NRS pain scores and as well as for PROMIS pain scores. So this technique works. It's the literature is growing in this arena from multiple different centers. Anecdotally, my practice would entirely highlight and confirm these results as well. Another very important component in the United States is the use of narcotics, and we have found, and this is one of Ian Valerio's slides, that the use of narcotics following TMR goes down dramatically. Just to say a few words about RPNIs. RPNIs, again, developed by the University of Michigan, are another adjunct technique. I use them with some frequency, often in combination with TMR. And just to give you an example, and I'll show a slide in a moment, if I'm doing a below knee amputation TMR or a revision for neuroma, I will often address the tibial nerve and the common perineal nerve with relatively standard TMR, and I will consider what to do with the medial and lateral sural nerves as well as the saphenous nerve, and sometimes I'm doing RPNI for those. So I believe it is a technique that we should have in our armamentarium, and both of these should be considered for all of these different types of cases. So just to show a video for kind of how I approach a delayed below knee amputee with established neuroma pain and how I do TMR. And there are many different iterations of this. I find this particular approach to be very easy. It takes about an hour to an hour and a half once you get familiar with the anatomy. It definitely works, and it's actually a fun operation to do. And my residents now have done so many of these with me that they're able to, you know, do them themselves or go out and practice and do this with real ease. So here's a picture, and then I'll show the video. So this is a patient in the prone position in the operating room with established neuroma pain following a below knee amputation. This incision is in the popliteal fossa. It's longitudinal, obviously. The popliteal fossa flexion crease or the knee flexion crease is up here. I generally do not cross that, which I think is a good idea. I have retracted the medial and the lateral sural nerves, which you can see here. And I have vessel loops around my donor nerves, which is the tibial nerve and the common perineal nerve. I basically fished out between the gastroc and the soleus laterally where the nerve runs around the fibular neck. So I'm going to play this video right now.
So we're in the popliteal fossa. This is a delayed below knee amputation TMR. We've identified the tibial nerve here, which you can see with the blue vessel loop. There are two motor branches coming off of the tibial nerve toward the lateral side. They likely represent tibialis posterior or flexor digitorum, and if we stimulate them, you'll see these are clearly motor branches of the tibial nerve. We're going to do our nerve transfer between the tibial nerve and these two recipient nerves. As we come laterally, we have a very large lateral soleus branch right here. And if we simulate that, you can see a very significant contraction of the soleus, nothing in the gastroc. So we're going to leave the medial and lateral gastrocs innervated through their native innervation, and we're going to do our common perineal nerve to this big lateral soleal branch transfer, as well as the tibial to these two branches off the tibial.
And again, you may consider doing TMR for the medial and lateral surals. Sometimes, depending on how many recipient nerves are available, I'll do TMR with them. Sometimes I'll do RPNI. So have all the tools in your toolbox to do what you perceive as best for the patient. Just an interesting case to share that highlights the combination of reconstructive microsurgery with TMR and contemporary nerve techniques. This is one of my favorite cases I've ever done. Published a case report in Journal of Hand Surgery, which took a long time to do for lots of reasons, but thankfully was able to get it in. And probably the only time I'll ever do this case in my life. So this is a guy who jumped in front of a train and had a mangled amputation of his right arm at the level of the elbow, which you can see here, but a relatively well-preserved forearm and hand. And on the contralateral side, somehow lost his thumb and his index finger. So this is a pretty devastating injury. I'm pretty aggressive with replantation, but that right upper extremity is not salvageable in my opinion. And what we did, this is sort of a unicorn because it's the only real indication to transfer the thumb from one side to the other acutely. But we did an acute thumb-to-thumb heterotopic replantation and also did a free flap from the forearm to cover the stump. So kind of two emergency free flaps here. Here's the thumb harvested as you would a toe to thumb. I went really proximally. The radial artery and cephalic vein are quite large. Makes a micro kind of macro surgery, if you will. You get long lengths of all the nerves and the tendons. Took the whole forearm based on the ulnar artery and basilic vein as a free flap to cover the stump. Here's what's left over as spare parts. And here you go. So it looks like a thumb because it is a thumb. Toe to thumb transfers work very, very well too, but there's nothing like original equipment here. So the thumb is a thumb. And you cover the stump in a very simplistic way with the free flap. But back to the point of this talk here, before I skin grafted the proximal aspect of his arm, I went back and did targeted muscle reinnervation in relatively standard fashion. What I also did was I innervated the free flap with the LABC. So this is a concept that I think is useful for the reconstructive microsurgeons who are listening. Very often if I'm doing ALT free flaps, even to the medial aspect of the lower extremity, and the saphenous nerve is injured or resected, I'll find a branch of lateral femoral cutaneous nerve and I'll innervate the flap with the saphenous nerve or something along those lines. So I'm always thinking when I'm doing reconstructive microsurgery about innervating my flaps, and because it not only will help potentially with sensibility, but also will prevent, potentially obviate the development of neuropathic pain. So just something to think about when you're doing lots of reconstructive microsurgery. Over time, he did pretty well. You can see I ended up doing a reamputation of his index finger. Here's his stump. It's very hard for a lot of these patients to get fancy prosthetics, but he's got great signals, and if his insurance company would ever cover it, he would be able to do it. I think in the interest of time, I'll show this video very quickly, but this guy went on to do well. He's got really good IP flexion, better function than most of my thumb replants do, and a lot of it's because of the extra length, almost like a transplant that you get, and you can control the Blix curve and the musculotendinous length quite a bit more. Okay, so let's talk about a few more innovations, things that kind of are new in my practice with regard to TMR and neuropathic pain surgery. And then lastly, I'll spend 5 minutes or so at the end talking through how I work up amputees, because I think that's something that I've learned a lot about in the past couple of years, and I would be happy to share that with you. So the traditional transhumeral targeted muscle reinnervation technique utilizes both an anterior and a posterior incision. And doing a fair amount of brachial plexus surgery, you can do all the nerve transfers through the anterior approach, including radial to axillary nerve transfers. So I thought to myself, gosh, why don't we just do all the TMR transhumerally through the anterior approach? And it turns out you can definitely do it. And it saves you time, it saves you a position change potentially, and it's not that hard to do. So we recently wrote this up in PRS Global Open, and I'll show 2 videos of how this is done, but it's basically the same technique, just with one incision. So this is a transhumeral amputation. To this side of the screen is the distal end of the limb. The axilla is over here, and we're looking at the anterior side with median and ulnar nerves, as well as the musculocutaneous nerve here. So I'm going to play this video.
Okay, so we have our donor nerves on the anterior side of the arm. This is the ulnar nerve right here. This is the median nerve. We've identified the branches of musculocutaneous. We have the brachialis branch, which is right here. We have the musculocutaneous continuing into the LABC right there. And then we have two biceps branches proximally. And I will go ahead and stimulate so we can see where we are. So this, again, this is a brachialis branch. This is no longer.
Just to pause for a second, you'll see as I'm stimulating, I've done a relatively long intraneural dissection of the brachialis branch. And in doing that, of course, just by pulling on the nerve, it's affected its stimulation of the brachialis. But as you do more TMR and more surgery in this area or any area of the body, you become very familiar with the branches. So you will see that this eventually does stimulate, but it's just a matter of me pulling on it a bit too much that it was a little slow to stimulate. There you go, a little stimulation there.
And then we have the biceps branches over here.
Okay.
Okay, so we have our donor nerve.
So
On the anterior side of the.
give me 1 second here. I'm going to the next one. Okay, so that's relatively standard anterior approach transhumeral TMR. But let's talk about how you can get to the radial nerve posteriorly in order to do your posterior TMR through the same incision. So as we all know, the radial nerve is kind of posterior to the humerus here. And if you go a bit proximal and just put your finger around the humerus in this sort of area, you will find the radial nerve, which I've identified here, as well as some of the motor branches that come off of it. So usually I'll choose the most distal motor branch and do a coaptation between the radial nerve proper and the motor branch into one of the triceps, whichever seems to be most distal.
Okay, this is a transhumeral TMR. We've already identified our donor nerves, which are the median nerve here. We have the ulnar nerve. We have the medial and brachiocutaneous nerve here. We've identified the radial nerve from this anterior approach, and you can see here's the majority of the radial nerve, and then this is a lateral head of the triceps branch. So you'll see when we stimulate this, that provides some triceps activation, and the radial nerve proper has very little here. So we're going to do our transfer between the radial nerve and the lateral head of the triceps, and we've seen some proximal motor branches that we will preserve. This is all done through the anterior approach.
Okay, so that's just one thing to keep in mind if you're doing a transhumeral TMR or even approaching neuromas in this area, that it all can be accessed through this anterior approach. This paper, which I wrote with Ian Valerio, one of my new partners, and just to say a few words about him, I'm so happy that he has come from Ohio State to join our practice at MGH. He's a dear friend, like he is Babak's as well, and I'm just so excited that he's here. And he and I have really been working a ton in the past 6 months or so together, and I'm really excited about working with him continuously in the future. So this paper we wrote together, which I believe combines TMR and RPNI in a very effective way, and this is the way that he and I both sort of independently came about doing this, and I'd like to share that with you. So here's the concept, and I'm going to really make this clear, hopefully. So often with TMR, you have a larger donor nerve than recipient motor nerve, and so there's an inherent size mismatch. And so what do you do about that? That's a question that comes up frequently. Well, one of the things that you can do if you have enough recipient motor nerves is you can actually splice the donor nerve and split it into a couple different components and do individual nerve transfers to multiple recipient motor nerves. And if you think about the BKA TMR example I showed for the tibial nerve, there were 2 recipients, and so I split the tibial nerve into 2 and did 2 coaptations. But if you don't have that available, or frankly, even if you do, one thing that you can do is to raise a vascularized but denervated, and that's important, denervated cuff of muscle to wrap around your nerve coaptation. And the concept is to combine the benefit of TMR, which is a nerve-to-nerve coaptation, which we know works, with the RPNI technique, which is to put denervated muscle around the nerve coaptation. So if there's any axons that escape, they will reinnervate the surrounding muscle. So just to go back 2 slides, we've called this targeted muscle reinnervation combined with a vascularized pedicled regenerative peripheral nerve interface. And this is very often how I'm doing TMR at the current time. So keep this in mind, and because it doesn't have to be either or. You don't have to only do TMR or only do RPNI. You can do both techniques, as I do, and you can also combine them, as we've shown here. Another evolving technique, which this paper is submitted, just not yet accepted, is doing TMR in the hand. So many of the folks listening, I'm sure, do a lot of hand surgery, and you can do TMR in the hand for the digital nerve. So here's a normal sort of schematic of the hand, of course. If you're doing a ray amputation, one of the things that you can do is to take your take the digital nerves and reroute them into the motor branches, which go into the interosseous muscles. They're very small, but they can be identified with the nerve stimulator, and this is not that difficult to do. If you look at partial hand amputations on both the radial and the ulnar side, you can also do TMR as well. And you should be careful not to take away the motor points into the thenar or the hypothenar muscles. The reason being that those are very superficial and very easy to access for myoelectric signals if you're going to have a more sophisticated prosthetic. But you do want to give the nerves a functional destination, particularly because these digital neuromas can be very painful for hand amputees, as many of you know. All right, so in the last 5 minutes or so, I want to share just a few words about how we evaluate amputees for neuropathic pain. A lot of these are similar themes to what I mentioned earlier for general neuromas, but this is a unique population. So here is my approach / our team approach. The first thing I would say is that we have a combined amputee clinic at Mass General Hospital, and I've found this to be unbelievably beneficial for patients, but also for us as surgeons. The people here that are listed are my close colleagues, Ian Valerio, you see at the bottom, but 2 orthopedic surgeons with whom I work very frequently. Marilyn Heng, who's an orthopedic trauma surgeon, Santiago Lozano, who's an orthopedic oncology surgeon, and we did a lot of amputations together and a lot of limb salvage together for doing free flaps and all this other stuff. So we already had a very close working relationship. So this was a natural transition and a very easy thing to do. And our practice for our amputee clinic has grown so significantly that it's totally outgrown the space, and the number of patients and from where they're coming is really dramatic. We have a lot of international patients now. So I would encourage all of you to consider this at your home institutions to build something like this. And we also have close contacts with physiatrists, infectious disease doctors, and David Crandell is a he's an excellent physiatrist who does a lot of work with amputees. So if we look at the reasons that patients have poor prosthetic use, the most common reason are pain, and this is borne out in many different studies. But the other reasons that can be true are poor prosthetic fit, and if there's heterotopic ossification or poor soft tissue coverage or poor myodesis, that's another reason. If the patients don't think that the prosthetics are benefiting them, particularly in the upper extremity, even the partial hand prosthetics are not commonly worn. If the prosthetic is very heavy, and that can be true for a person with a transhumeral amputation, these are very, very heavy prosthetics. Cosmesis is important to a lot of patients. And lastly, cost. And many insurance carriers will not pay for myoelectric prosthetics, and there's a limitation in how many prosthetics someone can get per year or per few years. I'm not going to belabor the data here, but lower limb amputees use their prosthetics far more than upper limb amputees. 84% in the lower limb, 56% in the upper limb. But pain is a major factor related to whether or not patients use that. And this has been borne out in numerous studies. So when I see a patient in the office, take a thorough history, of course, is important. But really, I think for these patients, you're going to spend a lot of time with them. This is not a 5-minute visit. This is not a person's got a trigger finger, either inject or offer surgery. These are longer visits. So you want to figure out what the etiology of amputation is, figure out how long it's been since the amputation, determine when the pain came about, how chronic the symptoms are, whether they're wearing a prosthetic, if so, for how long, have they had any soft tissue problems with open wounds or ulcers or even infections, and really to figure out how many hours a day can the patient wear their prosthetic. And I actually think that's a really important question, because these patients can be tough. And if someone's had chronic pain for a long time, they're probably always going to have some degree of pain. And we all know that, but it's definitely true. And if they wear their prosthetic for 15 minutes at a time before surgery, and after surgery, they're able to wear it for 6 hours at a time or even 4 hours at a time, that is a resounding success. And sometimes if they still have some degree of pain, they may not perceive it like that. But if you clearly document, hey, you could wear your prosthetic for 15 minutes before, and now you can wear it for 4 hours, that's a big difference. When you examine these patients, you want to really carefully examine their limb length, determine their soft tissue coverage, figure out if their myodesis is intact, make sure the range of motion is okay. We've seen a number of below knee amputees who have ridiculously stiff knees, where the best thing for them, frankly, is to convert them to an above knee amputation, to do TMR, and to get them moving right away. Tenel signs, I think, are important, and all the neuropathic symptoms become very important. But I often am not doing nerve blocks in these patients because you know what the problem is. For a below-knee amputee, you push right in the tibial nerve, you push right in the common peroneal nerve. It's obvious that that is a source of their discomfort, and they look at you when you do that like, oh my God, how did you know that was where the problem was? Well, that's where the nerves are. So I don't think these are real diagnostic dilemmas. The question is choosing the right patients for surgery. So my algorithm overall for treatment, and then we're going to wrap up here. We're keeping it just under an hour. Is to determine the etiology of their problem, if possible, to determine if it's nociceptive versus neuropathic pain. To learn about the chronicity of the pain and other patient factors, if it's a patient on chronic narcotics, or what's going on with the rest of their life, are they a good surgical candidate or not? You may consider a local anesthetic block, and particularly for non-amputees, I think this is a great idea. I very often do it for lower extremity neuromas, which is a huge part of my practice also. And then try to figure out if the pain can be improved with TMR or RPNI or nerve grafting. And should you do any bony or soft tissue revision procedures? And many of these operations, as I mentioned, now are done with orthopedic colleagues. It's actually great fun to do them. I'm doing them now with Ian. We often have multiple rooms going, so having multiple attendings is very useful. And this is I think a very, very good addition to one's practice. So finally, multidisciplinary approach is very important for pain patients. I do a lot of hand surgery as well, and if my practice was only taking care of patients with neuropathic pain, I don't think that would be ideal, and I'm sure many of you feel that way also. But we can help them, and it's nice to load the boat. So last two slides, food for thought. Patients with congenital amputations do not have a lot of phantom limb pain. So what that means is that if someone has a congenital amputation and they don't have any pain, their brain knows that everything's fine. But when someone has an amputation, the brain gets rewired. And if we can get to that problem early, if we can address it early, either with concurrent TMR, if we can, at the time of nerve injury, put in a nerve graft, whatever it might be, this is better than waiting years and years and years. Secondly, the brain changes after an amputation and changes after a nerve injury. And it changes not only in the anatomic location that corresponds within the motor and sensory homunculus that corresponds to the injury, but it changes in other places as well. And that's important to know. We also know, thirdly, that over time, pain usually increases as the pain becomes centralized. So I wouldn't say that there's an upper window of time after which I will not offer neuroma surgery or TMR, RPNI, nerve grafting surgery, but it does change the conversation in your discussion with the patient. And if someone's had neuropathic pain for a very, very long time, it's very unlikely that you're going to remedy it completely, but you often can make it better. So what's the future of amputee care? I think is a combined clinic with multidisciplinary approach. Most patients would benefit from surgery. And as I said earlier, this is one of the fastest growing parts of my practice. I literally tomorrow could just take care of amputees and neuromas and have a completely full practice. Again, I'm not going to do that for lots of reasons, but it's something that you really should consider. And these new techniques, again, championed and described by Greg Dumanian, Paul Sedurna, and others, really are profoundly impactful for our patients. So I'm going to stop there. I managed to keep it exactly to an hour, and I would be happy to answer any questions. And if anyone wants any of the papers that I showed, I'm happy to email them. So just shoot me an email. I'll get right back to you. So I want to again thank Babak, Greg, and the whole Buncke Clinic team, for whom I have immense respect for inviting me, and hope to see you guys in person soon. Thank you very much.
Kyle, thank you so much for a fantastic talk. This was really a great summary of the most recent advances that you and your team and others have made in the field of neuroma management, which as we know is a very difficult clinical challenge that we all face. I've got a few questions, some of my own and some from folks who've posted in the comment section. So let's say for a very common scenario that we all see, just a fairly distal finger amp, let's say somebody comes in, fingers amputated through the DIP joint, not salvageable. What do you do in that case? How do you manage the digital nerves in a fairly straightforward but somewhat distal amputation where the proximal TMRs may not be as much of an option primarily?
Sure. Well, the first thing I'll say is I don't know what the best thing to do is, but I'll tell you what I do and why I do it. And I've gone through a couple different iterations. So I think the basic premise is that you don't want the nerve endings exactly at the terminal aspect of the digit, because there's often there can be poor soft tissue coverage, but you don't want it right at the terminal aspect of the nerve where the working surfaces is, because that's going to be painful. So what I generally do now, and I think this probably works, although I can't prove it, is I'll take the digital nerve. I will do a bit of a traction neurectomy, so I will shorten them a bit. I will do a crush technique with microforceps to try to create a grade 2 to 3 Sunderland nerve injury more proximally. And then what I do is I'll take the individual fascicles, of which there are often 3 or 4, and I will splay them out and spread them out and move them dorsally. And the idea and the concept is that I'm trying to get those different small little fascicles to grow in different directions. I think it's good to not have all the axons and all the fascicles together in one sort of bolus, because I think that is it's neuromogenic, number one, but it also creates a big nidus for pain. So if you spread out the fascicles, I think that actually works. And I transpose it dorsally so that it's away from the volar surface of the digit. I hope that's clear.
Yeah, definitely. And I do something similar with that. I do crush it proximally, and I actually burn it distally as well a little bit to form an endogenous kind of neuroma cap almost by the time the fibers go out. And then I try to kind of move it away, as you mentioned, from the skin surface somewhere else that's not hopefully kind of pressure bearing. So I'm glad you mentioned TMR. In fact, we have Greg Dumandian giving us a talk later today at 5 p.m. Pacific time. So he'll go into a lot more detail there, and we're looking forward to hearing his results as well. We also had Paul Soderna a few weeks ago talk about RPNI, and there's the kind of perpetual debate of RPNI versus TMR, and obviously you and Ian have kind of combined them in some of your cases with the TMR with the vascularized yet denervated kind of muscle cuff. Paul obviously has his opinions about the superiority of RPNI over TMR. The question for you is, you mentioned that you do both TMR and RPNI. What is the decision tree there? When do you choose to do a TMR, and when do you choose to do an RPNI, and why?
Yeah, I mean, again, this is something that we don't know the ultimate answer to, and I'll share my thoughts. And as you mentioned, I do both. So I don't think you have to be in one camp or the other. I think that as peripheral nerve surgeons and microsurgeons, we should have all the tools in our toolbox. We should choose what we think is right. But the way I generally think of it is that if my general preference, I'll say this first, my general preference is to do TMR over RPNI. And the reason is that it's a bit more intuitive to me intellectually to have a nerve that you sew into another nerve, right? If you cut my median nerve right now, which I hope nobody does, I want my median nerve repaired to my median nerve. And nerves want to grow into endoneurial tubes. So I think that fundamentally, that to me makes a lot of sense. And I think that for larger nerves, conceptually, I think that's why I do it very often for what perhaps might be considered the most significant or largest nerves. RPNI, I do use, but I will use it depending on how many motor targets I have available. So sometimes if you don't have enough motor targets to accommodate all of your donor nerves, then the other remaining nerves I will consider to do RPNI for. Or a second thing to say is, if I think that a patient has poor protoplasm or has bad soft tissue coverage, and I don't think that undermining or dissecting further to identify more proximal motor branches is beneficial and could devascularize the end of the limb, I will often just go straight to RPNI up front in that type of situation. But most of the time, I will start out with TMR in our combined technique, and we'll use our RPNI for the remaining nerves, except in those other situations.
Great. You mentioned that nerves like to grow down endoneurial tubes, and obviously that is definitely true. One of the criticisms of TMR from a conceptual standpoint is you've taken this massive nerve, you plug it into a very small nerve, so the endoneurial tubes, if you will, don't really match up. In the traditional technique of TMR, where there's really no muscle cuff wrapped around it, what do you think is happening at that junction? Is there a neuroma? Clearly, clinically, it doesn't seem to be. Even if there's a neuroma, it doesn't seem to be something that's a problem, because clearly the data show that the technique works with regards to pain control and obviously with regards to prosthetic control. But what are your thoughts as to what's happening at that junction with a massive mismatch of fascicles?
Yeah, it's a great question. I thought a lot about this. I think if you have a size mismatch of a nerve, there has to be a neuroma that forms, right? That's what happens everywhere else in the body. So inherently, there will be a neuroma. The question is, will it be symptomatic or not? And I think if it's not symptomatic, which I think many times they're not, there are only a couple possible explanations. One is that there's sufficient amount of pruning of the axons as they regenerate that it kind of funnels into the terminal aspect of the nerve. I think that's one very logical conclusion. I think a second possible hypothesis is that, really all the brain needs is a circuit to be completed. And any part of the nerve that sort of gets through, and if it meets the muscle, it tends to calm the brain down. And the reason I think that is a pretty powerful reason is that, for those of you who've done a lot of TMR or taken care of a lot of TMR patients, what's really interesting what happens to them after surgery. They initially have a honeymoon period where you cut out the neuromas, they feel better usually, and they're like, great, this is okay. But then over the next 1 to 3 months, as the nerves start to regenerate, they start to get a lot of neuropathic pain, and they start to get a lot of electrical signaling. And if you don't tell them about this beforehand, they will torture you because they're thinking that something is wrong. But once you get over that hump, and once the nerve grows, through the TMR coaptation into the muscle, the brain just somehow, the switch turns off. It's really, really interesting. And I've seen that over and over and over again. It usually happens 3, 4, 5 months post-op. And it has to be that's when the nerve is getting into the muscle. So I think that, it's a long-winded answer, but I think pruning, and I think that reaching the muscular target, I think those are the reasons that happens.
Great. And now with with any procedure that we do, there's obviously going to be some failures. And so the question for either RPNI or TMR is, what do you do in a failed case? So somebody comes in, you've done a TMR, you've taken the the big nerves and used all your motor targets, if you will, locally. What do you do then? Do you then do an RPNI or vice versa? What are your thoughts?
Yeah, I haven't had too many, thankfully. But clearly, no technique is perfect. I mean, if anyone says that, they're just not telling the truth. I think it really depends on, in my mind, whether I think that it's something that I can fix or not. And a lot of times it depends on the patient. So there are patients that before surgery, they come in, they're on, 20 different psych meds, and they have, 18 allergies, and they're, 4 different types of narcotics. And you have long discussions with them, and you're going to offer them the operation, but you're not certain if they're going to get better, just given all the other psychosocial factors involved.
Mm-hmm.
If those patients still had pain afterwards, I'm not very inclined to offer them revision surgery, because what am I going to do? It's very unlikely you're going to make them better, but you gave it a shot, and often they're a little bit better. That's very different from the patient who gets better after surgery and over time maybe has one specific spot that they say, this one spot really hurts, where, maybe the coaptation pulled apart, or maybe the size of mismatch was too great. And if there's a focal area, I would consider offering revision surgery and then doing whatever it is that seems to be the best. You could use RPNI, you could use a nerve cap, you could use relocation nerve grafting, you could, splay the nerve into a bunch of, there's all these things that you can do. But if there's a focal problem, I might be inclined to offer revision surgery. But otherwise, if it's not a focal problem, I hit the pause button and I don't offer additional surgery.
Yeah, and I think another clinical scenario that I find very challenging personally is not even an end neuroma, but a neuroma in continuity. So you have a neuroma in continuity of an important nerve where you have decent distal function. So a patient has a lot of pain at the coaptation site, but their distal function is good enough that it makes it challenging if you can't tease away the normal fascicles from the abnormal ones. So a clinical scenario where you have a neuroma in continuity, severe pain, but good distal function, where you're unable to tease away scar from good fascicles. What do you do in that kind of case?
Well, those are, I think, some of the hardest cases that one can face in nerve surgery. And because you don't want to take away function, but the person has horrible pain. And those are very long conversations in the office. And very often what I will do is I'll tell the patient, look, I'm going to try to go in there and I'm going to try to do a careful microscopic intraneural neurolysis and preserve the function that you have. And if I can resect the neuroma, I'll graft it at that point. But if I can't, or if it seems like it's not possible to do that, then we have to go to plan B. And plan B, in my mind, is doing something that's extrinsically around the nerve to try to protect it. And that protection could be in the form of a nerve protector or some sort of a wrap, and there are many different varieties, or to use autologous tissue. And that can come in the form of pedicled fascial flaps, which I think are very useful in the forearm. Free flaps. I mean, Henk Koort has a great series in the Netherlands of doing this for failed carpal tunnel and median nerve problems. But I think at that point, my backup is extrinsic cushioning, not doing anything to the inside of the nerve. And then if all else fails, you could always go back and resect the nerve and graft it. But that's a much bigger deal. And I think they would have to fail the extrinsic cushioning then before you do that.
Yeah, I think that those are exactly my thoughts. I think that soft tissue augmentation in a case where you're unable to tease away the normal from abnormal fascicles and scar, and also you don't want to necessarily sacrifice distal function yet. I think flaps are great. As you mentioned, our dear friend Henk Koort has written on that with muscle flaps, does a lot of gracilis flaps for coverage of painful nerves. Our Italian colleagues have written about that with Bruno Battiston, Roberto Adani with muscle flaps and so on, and also fascial flaps and fasciocutaneous flaps. So that's definitely true, and I think it's a good tool to have. I'm going to have one last question before I go to Dr. Greg Buncke, who I know is on and has turned his mic on, so he has a question. This is a bit of a different topic, but do you have any thoughts on the treatment of a very difficult problem, which is brachial plexus neuralgia?
I do have some thoughts and I have no answers, but before I do that, I sort of wonder, I don't know why I'm just thinking about this now, whether the muscle flap coverage that's been described, you sort of wonder if that denervated muscle, if there's just something about it that's welcoming to the nerve. It's almost like vascularized RPNI. I know you're not doing anything intrinsically to the nerve, but you just wonder if there's something about that that's helpful. That'd probably be interesting to study. But back to your question of brachial plexus neuralgia. These are, I mean, unbelievably tough problems. You know, I think for me, it depends on whether there's, if you have root avulsion injuries, those are, I don't have a solution for that. I know the Dres procedure has been described, and Ellen Belzberg at Hopkins has done it a number of times. It's certainly not in my wheelhouse, but aside from that and all the neuropathic pain medications, I don't have any great solutions for brachial plexus root avulsion injuries. For neuralgia of the plexus, it sort of depends on what the etiology is. You know, very often if you have a truncal level injury and you're going to be going in and resecting and grafting or even doing nerve transfers, often that can help with the pain. That's more of a functional intervention than it is a pain intervention per se, but I really wish I had a better solution because it's a huge problem, and I don't know of anyone that has a fantastic solution for that. So I'm sorry I can't offer anything more than that.
Yeah, no, it is a very difficult problem. Greg, I know you're on. Do you have a question or comment for Kyle?
Yeah, Kyle, great talk. Really nice to hear how what you're doing, especially with this multidiscipline work. And my question has to do with this. You know, I've obviously been dealing with crazy patients that have nerve pain, and a lot of them are related to neuromas. But do you have any tricks for trying to figure out patients that have, you know, especially the chronic pain types that have psychological overlays? And you know, I use injections often of neuromas or painful nerves to try to give the patients an image of what that is going to be like long term. But I still have, I mean, I have many albatrosses hanging around my necks over the years. And if you have any tricks on how to keep those patients away or not operate on them, I'd love to hear it.
Yeah, well, certainly I'm not going to have really anything to teach you, Greg, but I'll share with you my thoughts. I think that, and I have plenty of those patients myself, I think diagnostic blocks are really important for those patients. And the quote crazier I think they are, or the more difficult they are to treat, the more times I will give them a block before offering them surgery. And I think that that's one of the ways that I'll often say, look, we need to make sure this works repeatedly before even considering surgery. So I think that's one component of it. I think that loading the boat ahead of time, and that's where this of other specialties, particularly pain management ahead of time, I think that really has made a difference in my practice because, you know, not everyone's going to do perfectly. And if the patient has seen pain management beforehand and the pain management team or one person or two people in particular have buy-in where they met the patient and they know what you're going to do, you've made the decision together, when they go back to see them afterwards, they don't perceive it as a dump where someone's like, oh, failed surgery, go back to see pain management. So I think those things can be helpful. But at the end of the day, patients with really severe nerve pain, you're either going to operate on them or you're not. And I think you have to have really thick skin if you're going to embark on a practice where you're taking care of lots of these patients. And there's going to be some patients who come in crying and hugging you and bringing you wine and all sorts of other stuff because you've helped them so profoundly. And there's some people that you're worried they're going to bring in a gun to your office.
Yep,
And I don't I wish I had a way to separate them. Of course we all do, but I don't know. And we all want to help people, so I perhaps I'm someone who talked into surgery more than somebody else who's like, just absolutely not dealing with it. And I think if you have this practice, as I know you do also, you got to take on the hard cases. If you don't do that, anyone can take care of a simple little problem. So those are my overall thoughts. Loading the boat. I think diagnostic nerve blocks are helpful. Really make the patient work to have surgery. I think those are the keys I've found.
I think your concept of getting pain management preoperatively involved on the patient is a good idea, because then this idea of dumping them on them later, it makes it easier.
Yeah, I found that it's very easy in our setting to have collaborative efforts, and as I mentioned with the Amputee Center, I was working a lot with the orthopedic surgeons doing limb salvage and free flaps and sarcoma reconstruction. So it was a very natural transition to say, hey, we should see patients together. We already had 10 patients each clinic. So that was easy. The pain management is a bit different because there's not as much overlap clearly. But what I did, and actually which made a big difference, was I gave a talk, maybe similar to this, but a pain type talk about surgical management of pain to the pain management group. And I invited any of them to reach out to me afterwards. And there were 2 people from the pain management group that emailed me afterwards. And I said, oh, great. These are going to be the people who are interested. So I sat down and had coffee with them, maybe a beer, I don't remember, but it was a very fruitful discussion. And it turns out that we had a lot of our goals were shared. And what I have found that they want is they don't want surgeons to just be total cowboys and just go in and do whatever they think and be like, oh, it didn't work. So once they see that you're thoughtful about it, that you've got these new techniques, which I think is very useful, they want to be at the table with you. And I didn't mention this here, but we actually have a multidisciplinary pain conference that we have once a month that I run and we just present really tough cases. And in fact, the cases that you're talking about, the ones that are not failed, but really, really tough, I present them and I say, what does everyone think? Here's what I was thinking about. Here's what I did. Here's what I didn't do. And if it's a patient that you think to yourself, I don't really want to operate on this person, I guarantee you the pain management folks are going to have some ideas about what they can do beforehand. So have them do that first. So it really, that's been a huge advance in my practice also.
Perfect. Thank you.
Great. Thank you so much, Kyle. I think on that note, we'll wrap things up. Kyle, thank you so much for being with us. This was an incredible talk, and in some ways, this week is Peripheral Nerve Week. Obviously, there was your talk this morning, and we have Greg Dumanian this afternoon or early evening at 5 p.m. Pacific time, speaking on TMR, and then on Friday morning we have Dr. Lee Dellin discussing joint denervation, which is one of his kind of newest areas of focus. So a really interesting week for folks who are interested in peripheral nerve. But Kyle, thank you again. It was really, every time I hear your talks, I learned something new. And it's great to see you, although it's better to see you in person, hopefully soon.
Well, thank you very much for having me. I appreciate everyone's time.
Great. And say hi to everyone in Boston, all of our friends there, and stay safe.
Will do.
Great. Thanks so much. Have a nice day. Bye-bye.